We shall go on to our first speaker, Dr. Mukesh Taneja, who's again from LV Prasad Eye Institute, senior consultant from cornea and anterior segment services. And he's going to talk on something very...
So I shall be talking about mammography and its current use in dry eye diagnostic. Would like to thank Dr. Chitra for giving me this opportunity to present in this symposium. I have no financial interest in the subject matter which we are discussing today. A little bit of history. So Heinrich Niebaum was a professor of medicine in Germany way back in 1666 when he was just about 28-year-old. He gave the anatomical description of meibomian glands. At that time he called them tarsal glands, but in his honor, these are known as meibomian glands. And what he described 3 centuries ago, more than 3 centuries ago, has still stood the test of time. We know that there are about 25 to 40 meibomian glands in the upper lid and about 20 to 30 in the lower lid. These are comprised of various acini which open into a central duct, which open into an orifice on the lid margin. These secrete a sebum or a lipid which provides a smooth optical surface for the cornea and provide the stability of the tear film. We know that meibomian gland dysfunction is the major cause. It responsible for about 20 to 40% of the dry eye disease that we see in the clinics. Traditionally, all of us have diagnosed meibomian gland dysfunction based on the signs in a patient. These are the plugging or the pouting orifices on the lid margins or the frothy secretions on the lid margins, telangiectasia, inspissated plugs, or the hyperkeratinization of the orifices. Some of these images have been taken from LVP, and I guess some are from Dr. Merle Fernandez. Mammography earlier used to be done by using the simple transilluminator, which would just go under the lid, and you will see a faint image, as you can see here, of the meibomian glands. Dr. Taipei in 1977 was the first person who combined a transilluminator with the infrared imaging device. He set it up on a slit lamp, and this is what was the first mammography system, I believe. About a decade ago, Dr. Pult from Germany and Professor Arita from Japan have done a very significant work in imaging meibomian gland, and they call it mammography. And this is a simple infrared imaging device which was created by Dr. Pult from Germany. He described what he called a Meibo scale based on the dropout of the meibomian glands. So degree 0 was when there were no dropouts. Degree 1 was 0 to 25% dropout. Degree 2 was 25 to 50%, and degree 3 was 50 to 75%. And degree 4 is more than 75 to total dropouts. Professor Arita combined the infrared devices with the software, and he devises a system whereby you can get an automated imaging, which also would give dropout areas. He calls it Meibo score instead of the Meibo scale. These are some of the images from his paper. These are the normal meibomian glands, as you can see in a person. This is a person who had a significant dry eye. You can see a very significant dropouts in this image. This patient had allergic conjunctivitis, and this is an old person who had a significant meibomian gland dysfunction. And you can see almost a total grade 3 on Meibo scale. What you basically have to understand is it's basically any infrared device will give you the images of the meibomian glands, because the sebum, which is there in the glands, it has the property to autofluorescence. So if you use a simple OCT device or an autorefractometer or anything which uses infrared imaging, you will be able to see the meibomian glands. So this paper described the use of Visante OCT to visualize the meibomian glands. And when I was at LVP, we had this Visante system. So I have used that Visante system because the CCD camera, it has an imaging system which is infrared based. So this is the images which I have taken there. So this is a patient who had a normal eyes, normal glands, and this patient had a dry eye, and you can see a significant dropouts. And this is a image taken on a simple autorefractometer. So even there, the meibomian glands stand out, as you can see. At present, there are many dry eye platform, which will give you automated analysis of the dry eye, which includes the automated interferometry, tear meniscus height, non-invasive tear film breakup time, and mammography. So most popular of these are SPM IDRA from Italy and Oculus from Germany. I had a chance to use IDRA for a significant time when I was in Cambodia last year. So it gives you automated NIBUT, the mammography in a test report form, which you can actually share with the patient. It gives you a follow-up data, all the data in the previous images, whether the patient is improving in his dry eyes or not, and it's very useful in a clinic. Talking a bit about the management of meibomian gland dysfunction, again, traditionally, all of us have used lid scrubs, hot fermentation, use of azithromycin ointment at the lid margins, which has worked quite well for the patient. However, of late, there have been some automated devices which gives you, this is a LipiFlow, which is an automated system of doing a hot fermentation and a lid massage on the patient, which is very convenient. And many of you probably would be familiar with the IPL, which is an intense pulse light treatment, which works again very well for the dry eyes, majorly for the meibomian gland disease. Again, I had a chance to use the Tixel device, which is a thermomechanical device from Israel. It has a titanium tip, which heats up to 400 degrees centigrade and touches the lid just for about 8 milliseconds. And it's a very simple to use. We just need about 5 minutes for both the eyes. So 10 shots are given in 2 rows to the lower lid and to the upper lid of both the eyes. And the patient, I have treated, you give 3 treatment, 2 weeks apart. And I have treated about 50 patients, and with almost 80% success rates. I was so impressed with the result that I got it done for my own eyes, and with quite a good results. We saw in these patients, we analyzed the results. So the OSDI and the tear osmolarity scores significantly improved, as well as the NIBUT after about 6 weeks of follow-up. And we compared this data with the IPL data, and it compares very favorably, rather a little better than IPL. These results are under publication and will be soon out for everyone to see. To summarize, in the past decade, we believe that technology has evolved significantly to help us understand, diagnose, and treat MGD and dry eye disease much better than before. Thank you, everyone, for the patient listening.
Thanks a lot, Dr. Mukesh, for all that you said, and it was gave us a good insight about this mammography and the need. But I would like to ask 2 questions before I ask Rajesh to take on. Could I direct this question to Dr. Merle? Dr. Merle, you are there? Dr. Merle is not there. Okay. So any of the expert panel could answer this. Now, what system would you prefer to actually grade meibomian gland disease? Because there are different classifications which are there. Does it matter at all to have different classifications? Because is our treatment going to vary based on that? Who is going to take this answer? Dr. Sunita? Dr. Rama?
See, essentially here, I think we are not just looking at the grading. I think we're looking at the overall symptoms of the patient, starting from other tests as well, including your T-BERT and Schirmer's. Mammography is one of the ways of quantifying the disease into mild, moderate, and severe, and most of them have similar gradings of less than 25%, 20 to 50%, or 75%. So I think, irrespective of the score, I think if a patient has a mild to moderate form of the disease, these are the patients who will definitely benefit with the treatment options that are available.
So that means it answers my second question. So which subset of patients would benefit most from intermittent pulse therapies? Would you say that they should be the mild to moderate groups? Because I suppose the advanced group with obliterated glands, it actually makes no sense. Dr. Rajesh?
Yes, so when you
Yes, I think the point that you made, that if there are no functioning glands, what are you trying to achieve? If the glands have already cicatrized. Unlike sometimes, the question I have is for Mukesh only, that when you are imaging these glands, and if you have a lot of tarsal papillae, or how does these affect the imaging? Because there have been instances where after adequate treatment for the allergic conjunctivitis, when the lid condition improves, and then you do a repeat imaging, sometimes the gland dropout that you see initially, you image them much better. So what has been your experience?
I have not analyzed in that situation, but in the sense, as I said, basically what you are imaging is the autofluorescence, and if there is a barrier to that imaging, yes, you probably would interpret this as a dropout, which may not be there. But you are very right in the sense, when I have not seen the dropouts which were there earlier and after that they have improved. I mean, anatomically, it does not make sense. So if you're seeing imaging improves after the treatment, so probably there is something which is going on, and one of the possibilities that there was some fault in the imaging. That is a possibility. There is at least one or two papers exist where they have tried to basically analyze or synchronize what you see, the signs as well as the images, and they have seen that it corresponds significantly well when you are seeing much of telangiectasia or a plugging, and you also see those distortions on the measurement gland. So it fares completely. I mean, it compares very favorably with the two of things. But what Dr. Chitra said, I agree that to treat a patient who don't really need a mammography, you can treat them even on a physical signs which you see in a patient. But now that I'm in a private practice, it becomes it becomes easy to explain to the patient, okay, this is the problem and this is what we are treating. So the patient satisfaction or understanding improves when you're using these imaging devices, or also in the grading, or if you're doing some studies, it helps. But otherwise, as far as the managing a patient of MGD is concerned, no, you can very well manage them without mammography. I think that is what Dr. Chitra was trying to say.
Would you have a cutoff of a lipid value below which you would feel that, yes, we could treat these patients? Because otherwise, we would be moving on to our next talk with not enough clarity whether it actually does have a major role. Because either we have to follow up these patients, again do a mammography and find out whether the glands have improved, which is less likely. So would there be any cutoff value at least when you would say, or it is just a glorified heat treatment?
As far as the treatment is concerned, yes, I would agree. Like a part of it is the symptomatic relief that the patient gets. So even if, it is known that probably it has some effect on the nerve at the neurological level, and which obliterates the pain which is coming from the inflammatory angle, which is obliterated by these treatment, and maybe the mammalian gland function is not really getting improved. So I would, in a practice, I do not ask the patient to stop the physical or the routine treatment, which is application of the either the steroids or the doxycycline or the azithromycin ointment. I do this concurrently with the conventional treatment.
Okay. Dr. Harshvardhan, you have anything to add?
Yeah, just usually people ask which is better, is IPL better or LipiFlow better? My understanding is that they both complement each other. Maybe LipiFlow as the first treatment and followed by IPL. Maybe Dr. Anaga can answer that. Yeah.
Can I just make a quick comment?
Yes, sure. Yes, Nanaga.
Actually, both LipiFlow and it's difficult to have access to both, especially in private practice. Ma'am, one thing we have observed is when the technician is actually doing the myography, if there is some glare or some shining light on the patient's eye, then sometimes it can be miscalculated. In the SPM, for example, they give you the percentage of meibomian gland loss. So sometimes you have a normal eye, but you can still get it at 100% loss. So you have to just be a little more careful with that. And another thing is, many times we have seen that even these patients, though they have a lot of signs, they may not have symptoms and vice versa. So there could be a lot of disconnect between the symptoms and signs. So I think what we are doing in our place is we are screening those patients who have some symptoms, and especially those who have a lot of exposure to computer use and digital use, and high risk patients like chronic diabetics and patients who are on chronic anti-glaucoma medications, and those who are having symptoms or chronic contact lens users. And many of these patients also show signs, so they may not be extremely symptomatic. So we have found a lot of disconnect between the signs and symptoms.
Yes, I do believe on that. Any final note, Dr. Rajesh, before we go on to our next speaker?
Yes, I agree. There are a lot of treatment options for meibomian gland dysfunction. LipiFlow, I understand the mechanism of treatment. It's basically you are trying to express the glands.
Yeah.
The mode of action is questionable, but yes, they do seem to provide some amount of symptomatic relief, both the IPL and the TICSA.
Okay, thank you.